Prostate cancer is normally diagnosed on the basis of a blood test. The blood test is called the PSA. Unfortunately, prostate cancer has to be quite advanced, in other words, have to have grown quite a lot in order for it to give you symptoms. And therefore we rely on the blood test, the PSA, to try and detect that cancer before it's got large and before it's given rise to some symptoms. The PSA has some problems. The PSA can diagnose prostate cancer early when the disease is very much curable, but it can also be falsely high when you have not got prostate cancer. So many men have a slightly higher PSA and they don't have prostate cancer. They would therefore be put through a number of investigations, and it's reassuring for us to be able to tell them at the end of it all their investigations are negative. But the PSA may in the meantime have given them some anxiety. PSA is very useful also at monitoring treatment going forward. So if you do have prostate cancer and you need to have treatment, after that treatment, PSA is very reliable at telling us whether the cancer's all gone or whether it's the signs that unfortunately it may have come back. So if the PSA is high, what we do is check that you don't have any sign of infection, and if that was the case, you did not have an infection, we then proceed to the next investigation, which would be an MRI scan normally. This is an MRI scan that looks inside the prostate to see if there's any abnormality in the prostate that may either be prostate cancer or something else that might be elevating the PSA. So we know that most men will develop prostate cancer if they live long enough, and most men will develop prostate cancer that they'll never know about in their lifetime. They will live a normal, full, healthy life unaware they have prostate cancer. Sometimes these prostate cancers are found either on a biopsy or an MRI scan, and because we think they're never going to affect the patient during their normal lifetime, we recommend what's called active surveillance. And with active surveillance, what we do is we watch patients very carefully with a combination of the blood test, the PSA, an MRI scan, and also sometimes biopsies to make sure that the cancer isn't changing. But essentially, this is a way of monitoring cancers that we think are never likely to affect that patient during their lifetime. Sometimes these cancers may show signs of change, and then we'll then treat you with one of the normal therapies for prostate cancer, such as having your prostate removed, radiotherapy, brachytherapy, or focal therapy. But the vast majority of people who start on active surveillance stay on active surveillance, stay being monitored, in other words, without the need for any form of treatment. The challenges of making a diagnosis of prostate cancer lie really in the form of the blood test, the PSA, which doesn't always tell us whether there's cancer there or not, interpreting the MRI scan, and then once we've done the MRI scan, if we need to proceed to do a prostate biopsy, interpreting the biopsy findings to decide what the best treatment options are. So in terms of making a diagnosis in the first place, we do this based on the PSA blood test. And the PSA blood test may be high even if you don't have prostate cancer. This could be because the prostate is a little enlarged, and larger prostates, even though they don't have cancer, may put the PSA up than a smaller prostate. The other challenge is if you have a urinary tract infection, that can also elevate the PSA. So what we do is we look at a number of things, such as what's happened to the PSA over time, make sure you haven't got a urinary tract infection, and look at the size of the prostate to decide whether or not, based on the PSA, there's likely to be prostate cancer there. If we do feel there's a high chance there's prostate cancer, then we would then go on and get an MRI scan. Now, MRI scans don't always give a black and white answer. They're much more accurate than a PSA test. They're much more accurate than a patient who might have symptoms or even the finger examination at the back passage, but they don't always give us a black and white answer. So what we may do is do a biopsy if we think that the MRI shows there's definitely cancer. If the MRI is a bit equivocal, in other words, it says there may or may not be cancer, we then make a decision based on the prostate size and the PSA as whether or not a biopsy is necessary. Often the MRI is completely normal, and therefore you wouldn't need to have any biopsy at all, but maybe just carry on watching your blood test, your PSA, going forward just to check. So a patient who has undergone an MRI may have an abnormal area that appears on that MRI scan. MRI is fantastic at looking inside the prostate to see if there is any prostate cancer there. When we do a biopsy, we can't unfortunately do this using an MRI scanner to identify exactly where the tumour is. An MRI scanner is a noisy tunnel, and it would be difficult for a urologist to get in to access the prostate down that noisy tunnel to know they get the right bit. So what we do is we do what's called an ultrasound scan by placing a small probe up the backside. Ultrasound scan is very good at showing where the prostate is and the size and shape of the prostate, but unfortunately it doesn't give detail about what's going on right inside the prostate. So what fusion biopsies have done, and this is a development really in the last few years, is it's taken the MRI scan, and what we do is we outline the prostate on the MRI scan and we outline the abnormal area on the MRI scan, and then we fuse those outlines with the ultrasound image. This enables me to see on the ultrasound image the abnormalities that we've detected on the MRI scan. What I can then do with a fusion biopsy is put a needle directly into what is seen on the MRI scan using the ultrasound scan, so I know I've hit the right target. The fusion biopsies then also record exactly where I've taken my biopsy, so we have a record going forward of exactly where that abnormality is and where the biopsy was positive for prostate cancer or negative for prostate cancer, as this can impact on treatment going forward. So the three biggest risk factors of prostate cancer, unfortunately, there's nothing we can do about. That is the family history. So if you have a father or a brother, then you're at increased risk of prostate cancer. And depending on how many relatives you have who have prostate cancer, that increases your risk even further. But clearly you can't do anything about that. The second thing is getting older, which none of us can do anything about. And finally, your ethnicity. If you're a black man, you're at increased risk, unfortunately, of developing prostate cancer over a white person living in the same country. So we can do nothing about that, but what we can do things about are reducing your risk of getting cancer overall, and particularly prostate cancer. So exercise reduces your risk of prostate cancer. Making sure you're not overweight reduces your risk of prostate cancer. And particularly in the diet, having cruciferous vegetables, those are things like kale, broccoli, Brussels sprouts are all good ways of not only maintaining a good healthy diet, but also reducing your prostate cancer. There is some evidence that lycopene in tomatoes, that's tomatoes ground up rather than whole as in salad tomatoes, may help. And also pomegranates may help.